Burr Ridge, Ерік Muehlbauer з доповіддю Strategies to minimize risk in spine surgery, як зменшити ризики хірургії хребта. Будь ласка.
Hello, everyone. Sorry that I can't be there in person, and sorry for my informal presentation. I am playing soccer today with a Polish club called Strategii. So, dzień dobry. We're playing a Lithuanian team today. So, congratulations to Vladimir and the team on a great a great 21st meeting. I really hope next year I can be there in person. So please, let's roll the video, okay?
Okay. Play good.
I'll score a goal for you.
Muehlbauer, I'm the CEO of North American Spine Society, and I really wish I could be there in person, but hopefully next year things will calm down and we can all be together. Before we get started, I'd like to congratulate the organizing committee, especially Vladimir Rodchenko and the team, Drs. Balan, Dr. Puntkowski, Dr. Zicalo, and Wojtniska on the congratulations on the 21st International Symposium on minimally invasive and instrumented surgery of the spine. And what I'm going to talk about today is risk assessment for spine surgery. And it's a somewhat complex subject, so let's dive in. So at some point, things will fail. Humans make mistakes. To err is human. There was a very big report on this several years ago. Protocols will fail, checklists will fail, processes will fail, and then harm might reach a patient. And it's really because humans are the ones that are using these systems. And let's look at the airline industry. You know, we've learned a lot from them over the years. And airline officials would like you to think that your cell phones and computers will interfere with an airplane's complex and sensitive electronics, leading to a crash if you don't turn them off. But that's not true. The real reason the airlines want you to turn off your electronic equipment is because of the potential distraction to you during the most dangerous parts of the flight. The most dangerous phases of the flight are during taxi, takeoff, climb to 10,000 feet, and then during descent out of 10,000 and approach and landing. So they want you to shut everything down so that if the flight attendants need your attention, they can get it. And if you look at things from minimizing distraction, you can realize an 8-fold increase in patient safety. So again, like I said, the FAA wants you to shut off your electronics so that you are not distracted. In fact, pilots are prevented from chatting or doing paperwork during these phases of the flights as well. They call it the sterile cockpit. And during those times, the only communication or activity that's allowed must be directly related to the operation of the airplane. Pilots taxiing to the runway for takeoff who are caught by the FDA chatting about what they had for dinner last night can easily lose their pilot's license. Distraction kills. Distracted clinicians can also cause harm to patients. There was a UK study that was published, and there are some fairly simple distractions that can occur during surgery. I'm sure you all know them. An unexpected movement by another, a cell phone ringing, unrelated conversation, noise from a metal tray, question about a problem with another patient, a resident's career choice. Simple distractions such as these can have caused an 8-fold increase in major medical mistakes during surgical procedures. And additionally, more than 50% of the physicians in the study forgot a key task when these distractions were present. So they're common, and they happen in everyday facilities. Some hospitals and surgeons have adopted the term Delta to signify that it's time for everybody to focus. Anyone on the surgical team can call it out and invoke the protocol of sterile cockpit. They use the word Delta. It means the undivided attention of all clinicians involved in the care of the patient is needed immediately. all social conversation should cease. The music should be turned off. All unnecessary and non-operational movement should cease. Paperwork or other activities should stop. Everybody should focus on the patient and the task at hand. And there's nothing specific about the word delta. You can use whatever word you want, but delta seems to be something that everybody understands. So there's also quiet zones and other safety tactics. So for example, if a nurse or somebody else is entering a medication order, they should be in an area where it's a quiet zone. Some places they put up signs that say, be quiet, we're in a med zone. Other distraction control tactics include having nurses wear brightly colored safety vests when giving medications. These are low tech and low cost, but they do work. But again, using the term delta or something like that can also create a quiet place where nurses can put in medication orders without being interrupted. So it's not just for the surgical suite. So let's look at some of the literature that's out there. So my friend Sohel Mirza, Rick Deo, and some others, they did a risk assessment of adverse events in spine, and they tried to figure out really the causes of those. So they looked at patient characteristics, they looked at disease attributes, they looked at treatment factors, and how each of these things could contribute to an adverse outcome. And it really just gives you a framework for assessing the level of risk that you're facing. And they looked at different procedures: anterior decompression, fusion, instrumentation, posterior decompression, fusion, instrumentation. So, and they also looked at the number of levels operated on, the number that were instrumented, number of interbodies, decompressions, osteotomies, instrumentation removal, bone quality, all of these different things. So they came up with this graphical grid for coding surgical procedures, right? So what you do is you go to the grid, you look at the disease level, and indicate what you're going to be doing, which level you're going to be working at, so that you can get kind of a graphical picture of the risk that you're about to undertake with any given patient. Again, the more this is filled up, the higher the risk is going to be for that patient. So the key indicators that they discovered for the risk were, again, the invasiveness of the procedure, the duration, and blood loss. Difficult to agree on all the exact parameters, but the researchers consistently identified errors related to technical issues, communication, or systems failures. So here's the results of their work. Again, technical errors, equipment failure in communication, or other system failures were the key things, and we'll get into that in just a little bit. So there's also been a comorbidity index that is predictive of post-operative clinical outcomes, and they just did this about single-level posterior interbody fusion surgery, and this was widely known to become the Charleston Comorbidity Index. And there's also the surgical risk calculator from the American College of Surgeons. You can go to their website, and it's called riskcalculator.facs.org, and you can go to the NSQIP surgical risk calculator. This is an online tool that you can use. It's pretty handy. There's the Nijmegen decision tool for chronic low back pain, and it's a development of a clinical decision tool for secondary or tertiary spine care specialists. Again, they looked at the biosocial and psychosocial factors, looking at patient assessment. There's a lot of tools out there. There's something called the +1, and there's a research article by Van Hoof, and in this study, they wanted to know if patient-reported profiles help avoid unnecessary referral to a spine surgeon. So this was mitigating risk by avoiding the surgery altogether. So the other thing that you have to look at is the probability of benefit. In many major spine surgeries, typically there will be complications. Will the complications be transient or permanent? How will they affect the outcomes? What's the probability of the patient improving? And who decides if the risk is worth it? Is it the surgeon, the patient, the payer, or is it a combination thereof? And which medical comorbidity scale is the most helpful? Is some sort of frailty index a better way to go? Combining surgical invasiveness and frailty might better predict patient-specific complications. Now we'll take a look at modifiable risk factors. So these are defined as risk factors that can be mitigated through patient lifestyle and diet change. Things like hypertension, high cholesterol, substance abuse, alcohol, nicotine, opioid abuse, obesity, and malnutrition. These are all modifiable risk factors. I'm sure you all know about these things. But these modifiable risk factors can generally be categorized in one of three categories. Again, they're vascular. Okay, so that's dyslipidemia and hypertension, substance abuse, which is alcohol, tobacco, and opioid, and then dietary, which is malnutrition and obesity. So in this study, there were 30,000 patients that were analyzed, and they analyzed the risks of the various modifiable risk factor subgroups within the surgical cohort, and it was pretty evenly spread out with about 9,500 each. So smoking is strongly associated with increased risk of surgical site infections and other perioperative complications, including decreased blood flow and impaired wound healing. Obesity is linked to increased risk of postoperative complications, including infections and longer operative times, increased length of stay. Diabetes is associated with higher rates of postoperative complications, including infections and the risk for revision surgery. Nutritional malnutrition is often indicated by low albumin levels. It's linked to increased risk of infections and prolonged length of stay. Hypertension can increase the risk of dyspnea and readmission after ACDF. High cholesterol is also associated with increased risk of readmission following ACDF. Osteoporosis can impair bone graft healing and increase the risk of non-union. Mental health status issues such as depression are associated with increased complications after spinal deformity. And substance abuse and alcohol abuse are also things to keep in mind. So how do these things affect outcomes? Well, there's increased risk of infections. Smoking, diabetes, obesity, and malnutrition are all associated with those. It can also delay fusions. They can occur with osteoporosis, diabetes. Chronic steroid use can impair bone graft healing. Hypertension and obesity and malnutrition can lead to increased readmission rates. Obesity and malnutrition can lead to longer hospital stays. Obesity, as we mentioned, can lead to increased operative time. And, there's altered biomechanics and muscle atrophy. So sometimes the surgery itself will lead to things that you really don't plan for because the biomechanics are different and then muscles can atrophy. So the strategies to address these modifiable risk factors, again, smoking cessation, weight management, diabetes management, nutritional support, hypertension and dyslipidemia management, mental health support, substance abuse treatment, alcohol use reduction are all things you can do to improve outcomes. So again, in this 30,000 patient study, you can see the breakdown: substance abuse, vascular, and dietetic issues all had fairly similar scores across the board, all added to the cost, the inpatient hospital costs, all had some length of stay, some higher, some lower, and all definitely had an impact on the quality of care. So the things that they looked at were, again, medical complications, as mentioned before, surgical, hematoma, things like that, non-routine discharges and readmissions. So again, dietary and vascular MRF had about a 9% independently reported significantly higher rates of medical complications. And here's the table that shows all of the different complication rates for the cohorts. And again, looking at the ICD-10 diagnosis codes for primary reason for readmission for each of those different areas. Again, the key findings that modifiable risk factors, dietary, obesity, and malnutrition contribute to a higher risk of increased postoperative complications, length of stay, and non-routine discharge. Patients with diagnosed substance abuse issues reported significantly higher rates of readmission with 1 year, 1 year interval compared to those in other cohorts. And they had the highest rate of infection, actually the ones with the substance abuse. Vascular MRFs demonstrated the highest medical complications, and it could be partly explained by the physiologic influence of hypertension and high cholesterol. Hypertension in particular was associated with increased rates of dyspnea following ACDF procedures, and hypertension was also associated with an increased risk of readmission following spine surgery. So here's a really good resource for you. So Safety in Spine Surgery Project, if you go to safetyinspinesurgery.com or .org, it's run by Michael Vitale, who's a friend of mine. They've got best practice guidelines on their website. They've got all kinds of different resources on their website, presentations, risk severity scores, checklists, you name it. And in fact, they just concluded their 10th annual Safety in Spine Surgery Summit in New York just a day or two ago. So I encourage you to look at this website and improve your safety of your patient care. So thanks for making time for me today, and I hope the rest of the meeting goes well. Thanks.
Дякуємо. Дякуємо за гарну презентацію.